begin with, what I'd like to do is share a story. I just recently taught a course in Columbus, Ohio. And at the course of things, we got a group of parish nurses together, and they start telling their stories. And it's always inspiring to hear stories. And this one story that was told was so appropriate for the topic today. Sue Mooney is a parish nurse. She's been a parish nurse in Columbus at a large church for about 6 years. And she was telling the story of a lady that she had been visiting, one of her parishioners, had been in a nursing home for some time. She was 96 years old. And in the past year, when she would visit her, she would say, "Sue, I'm ready to go. I'm ready for the Lord to take me. My friends are gone. I'm just getting tired, so I'm ready to go." And they would talk about this. And one night, just prior to my visit down there, in fact, Sue received a phone call at 2 a.m. in the morning, and it was the emergency room saying that Mrs. So-and-so had been brought in. The veins in both her legs had been thrombosed, and the surgeons wanted to amputate her legs. But she kept saying no, she did not want her legs amputated, and she wanted her parish nurse, Sue Mooney, to come and talk to them. So I think it's amazing. The emergency room nurse took the time and effort to go through the phone directory, and at 2 a.m. call all the Mooneys in Columbus, Ohio, to find Sue Mooney, parish nurse. But she found her, and Sue went over to the hospital, and she talked with the doctors, and they were convinced, too, that this woman was very rational in her decision, and that she understood what the decision she was making, so they said they would abide by it. So the entourage of doctors left a resident in charge, and the resident said, "Now, I just have to tell you what the course of events will be, that if we don't amputate your legs, you will probably die, probably within a couple hours, and we will keep you comfortable, but I will see that you're transferred to the room so that you can be peaceful." And so they proceeded to take her to the unit. And much to Sue's surprise, the resident went along, Sue went along, 2 of the attendants from the emergency room went along. They got up to the floor, and the 2 attendants from the floor came in, put her in a bed, and they got them all settled. And there's 6 people standing around this frail little old lady. And the woman looked up and said, "Sue, sing in the garden for me, please." And Sue said, "Well, as soon as everybody leaves, I'll sing." And the doctor said, "No, you go ahead and sing." And she said, "Well, won't you all sing with me?" And they said, "No, you go ahead and sing." And Sue said that In the Garden wasn't one of her top 10 hymns, but she attempted to sing it. And she said even as she was singing, the woman, she got this beautiful, peaceful look on her face. Her respiration started slowing down. And she really felt, and I think everybody else did, that she had actually died in the midst of the song. So at the end of the first verse, Sue stopped, and everybody just stood reverently. But before anyone could do anything, the woman opened her eyes, looked up at the resident, and said, "Sue usually sings better than that." That's the role of a parish nurse. Dying with dignity are encompassed in the concept of health and the health ministry of the church. Parish nursing is a strategy to assist congregations to carrying out this health ministry. Has increased over the past 10 years as churches seek to reclaim their role in promoting health and wholeness throughout the lifespan, from conception to the physical death. The concept of parish nursing originated in the Lutheran healthcare system with Dr. Granger Westberg, who is a Lutheran pastor. And he felt that our health of the nation was not changing, that we had to bring health into the congregations to see significant changes. However, the title of health minister or parish nurse, since it came out of the Lutheran tradition, it's a concept that I'm going to be talking about, because the title may not be appropriate to your particular denomination or faith community. But a health minister is a person, let me get my view graphs here. Um, a health minister or a parish nurse is a way of integrating the biblical teachings of health and wholeness, sickness and brokenness into the work and worship of a congregation. A health minister is anyone who promotes health and healing and wholeness through the integration of body, mind, and soul with the environment as part of the ministry of the faith community. And I think that this is something to be emphasized. The basis for practice is a faith community. A parish nurse is a health minister who is a professional nurse who promotes health and healing and wholeness through the integration of body, mind, and soul, and the environment as part of the ministry of the faith community. She is on the staff of the faith community. Nursing as a profession is rooted in promoting the dignity of each person regardless of health state, from wellness to death. Nursing also has its roots in faith communities, having evolved from the religious orders which provided the only source of care outside the family until the advent of modern nursing. Parish nursing is reclaiming its heritage as making the parish or the faith community again becomes a practice site for nurses. Parish nurse practice is the integration of the art and science of nursing with the theology of health and wholeness and the faith practices of the church. Thus, parish nurses have a unique role and stake in dignity in dying. Biomedical and technological advances continue to press back the frontier of our understanding of the human body and how it maintains its physiological function with chemicals, surgery, replaceable parts, and even to sustain it mechanically. These advances have come to define health as the absence of physical disease and health care as the care of diseased bodies. The focus and challenges of the current healthcare system are to cure disease and to replace diseased body parts rather than to understand the person as a whole being, body, mind, and soul, which continually interacts with the environment. A redefinition of health as not only the absence of disease, but a sense of physical, psychological, spiritual, and social well-being, and of being in harmony with oneself, with others, the environment, and God is essential if dying with dignity is possible in today's healthcare system. A holistic understanding of health promotes the prevention of disease, the striving for wholeness and healing, which is making whole of brokenness, even when cure is not possible, and physical death is inevitable. Thomas Stroge wrote in The Faith Factor, disease cannot be described outside a person's life, beliefs, family history, and faith tradition. One may be healed, but not cured of disease. For example, a person that is dying of terminal cancer may perceive that he or she is dying as a whole person, having found meaning and purpose in their suffering, a sense of belonging to a loving family and a caring community, and an optimistic acceptance of their physical limitation and the hope for eternal life. On the other hand, one may be cured of disease, but not healed, such as the surgery that was successful, but the person died due to a lack of will to live, where there is not a physiological reason for the death. Health is wholeness, the integration of body, mind, and spirit. Salvation, shalom, these terms you've heard frequently this week. Brokenness is illness, disease, disintegration of the body and mind and spirit. Alienation from relationships and community, a sense of hopelessness and meaningless, and eventually death. The strength of a building depends on the pillars around which the structure is built. The health of an individual depends on the physical, psychological, sociological, and spiritual pillars around which God created each unique person. While the pillars may be weakened by disease from within or stresses from without, the strength of the other pillars may be strong enough to support the weakened pillars so that the person can heal and become whole. Only when the weakened pillars or broken pillars are not able to be shored up by medicine, positive attitude, meaningful relationships, and meaning and purpose in life is there disintegration and the pain and suffering of illness and death. I put up the pillars of the health illness continuum, and we start off with the continuum of brokenness to wholeness, and illness to health, and the physical continuum of death and cure, the psychological continuum of depression and optimism, the sociological continuum of belonging and alienation and belonging, and the spiritual of separation from God and salvation, hopelessness and meaning and purpose, and environmental harmony and disharmony. While nursing curricula continue to teach caring for the whole person, the art and science of nursing has increased in complexity and specialization in response to the demands of the advances in medicine and technology and the healthcare system, which has evolved. The reality of nursing practice is that most nurses are employed by institutions in the sickness-focused healthcare system, and they get their rewards by emulating the biomedical approach to sickness care, which leaves little time to address the emotional, spiritual, and social needs of the person and his or her family. The incongruence between what is taught and what is practiced has resulted in an identity crisis for the profession and for nurses. To clarify nursing's identity, numerous attempts have been made to define nursing and to find a theoretical basis for nursing practice. Most of these attempts have included the holistic nature of nursing, and while describing what nursing should be as a distinct healthcare profession, these definitions and their theories tend to have little influence on the realities of the priorities in the workplace and how nursing is practiced and rewarded. In 1961, in response to the rapid changes in healthcare delivery worldwide as a result of the advances in medicine and technology, Virginia Henderson, a renowned nursing leader, was asked by the International Council of Nurses to define what nursing is. And she wrote, "The unique function of the nurse is to assist the individual, sick or well, in the performance of those activities contributing to health or its recovery or to peaceful death, that he would perform unaided if he had the necessary strength, will, or knowledge, and to do this in such a way as to help him to gain independence as rapidly as possible." Henderson further elaborated that the nurse was a member of a team to carry out the total program, whether it be for the recovery from illness or to support death, and that the nurse is a substitute for what the patient lacks to make him complete, whole, and independent by the lack of physical strength, will, or knowledge. The wide acceptance of this seminal definition of nursing practice is attested to by its appearance as a basis for several nursing theories. It identifies key concepts which identify nursing practice as separate from medical practice. Nursing is a substitution for what the individual cannot do for himself. Nurses have a role along the entire health illness continuum, from wellness through death. And nurses promote health as completeness and wholeness, independence. Henderson wrote, "Think how rare completeness or wholeness of mind and body is. The nurse must, in a sense, get inside the skin of each of her patients in order to know what he needs. She is temporarily the consciousness of the unconscious, the love of life for the suicidal, the mouthpiece for those too weak or withdrawn to speak, and so on." And in 1989, Brenner and Roebel identified the concept of caring as primary for a nurse in making the connection with another person. They defined caring as being connected to people and having people, events, projects, and things matter. Caring is the essential requisite for all coping. Caring helps a person to recover, caring to appropriate meaning, and to maintain or reestablish connection. From the place of care, the person can neither claim complete autonomy nor be the absolute source of meaning. Involvement in caring may lead to one to experience loss of pain, but also may to loss and pain, but may also make joy and fulfillment possible. Caring is primary because it sets up the possibility of giving help and receiving help. These concepts from Henderson and from Benner and Warburg are the essence of parish nursing. Parish nursing balances the science of nursing with the art of nursing, medical knowledge and skills with theology and caring. The rapid growth of parish nursing practice is a response to Christ's command for the church to carry out its healing ministry by being a caring community, empowering people to use their wholeness to care for each other and their neighbors. Nurses have responded out of their frustration with the current healthcare system, which limits their ability to practice nursing as a vocation to which they were called by Christ's command to heal the sick, and the practice of nursing they were taught. A healthcare system which limits access to care based on disease diagnosis, the ability to pay, a system where cure rather than healing is the criteria of success, with physical death being the ultimate failure, a system which requires the nurse's time and energy to support the goals and values of the employing healthcare agency, leaving little time to establish a caring relationship in order to implement the substitution function of the nurse to assist the individual, sick or well, in the performance of those activities contributing to health when the patient lacks it to make him complete or whole, or its recovery to peaceful death, right, and peaceful death. I'm going to focus the presentation on the role of the parish nurse as a substitution role, as a ministry strategy in assisting individuals to peaceful death. This conference is a result of conflicting views between what society accepts as assisting an individual to peaceful death and what Christians should accept as assisting to peaceful death, based on biblical teachings of the sovereignty of God and the uniqueness of each individual. The words used to discuss the topics in this conference, dignity, dying, suffering, are defined differently based on a person's emotional, cultural, and religious context. In order to minimize confusion over the words, I'm going to use Webster's dictionary definitions. Dignity is defined as a quality of state of being worthy, honor, or esteem. Dying is to pass from physical life, to suffer or face the pains of death. And a term that we hear increasingly, and especially in this conference, is the term of euthanasia, which in Greek means the good death, and in English, the active practice of killing or permitting the death of hopelessly sick or injured individuals in a relatively painless way for reasons of mercy. And mercy is defined as the compassionate treatment of those in distress. Killing is to put to an end, to destroy the vital, essential quality of, and connotes premature violation of natural laws governing physical life and death. Life is the quality that distinguishes a vital and functioning being from a dead body. Now, we know that advances in medical science and technology can violate the natural laws governing life and death by prolonging the dying process, but has done little to prolong the vital and functioning being from a dead body. Hence the debate over the definition of life. What is a vital and functioning being as opposed to the dead, lacking in power to move, feel, or respond body? And who decides? It has been demonstrated that when life is defined just in physiological terms, it can be preserved for extended periods by mechanical means, which violate what many consider to be dignified death. This fear has led to laws recognizing advanced directions, which include the living will and may specify what unnatural or extraordinary means may be used to preserve physiological functioning, and the durable power of attorney, where the surrogate health care decision maker may be appointed to act on one's behalf when unable to make own decisions. However, there continues to be the fear of the pain of dying process, even when the extraordinary means are not used to maintain life, but when the person ceases to be what he or she defines as a vital, functioning being. This has widened the debate. The goal of a faith community is to promote movement from the end of the health continuum, motivated by fear of illness, brokenness, disintegration, hopelessness, and death, toward the desired goals of health as wholeness, integration, salvation, motivated by hope for its members and its neighbors. Anecdotal reports of those who choose or wish for a premature ending of life indicate the reasons to be the experience or fear of insufferable pain, a perception which may emanate from its, or is maybe exacerbated by the spiritual, social, and emotional causes as well as the physical causes. A loss of self-esteem and worth, dignity, a loss of relationships, sense of belonging to a caring family community, a lack of meaning and purpose in life, hopelessness. These are issues which are not addressed by the current healthcare system and must be addressed by the Christian churches in light of the biblical teaching. Faith communities, and specifically Christian churches, must reclaim their historical role in health and healing and dying. The Bible has numerous references to health and healing, wholeness and brokenness, salvation and physical death as natural order, but the life eternal as the hope for believers. Dr. Martin Marty has said that all the Gospels are about health and healing. The great commandment, you shall love the Lord your God with all your heart, with all your soul, and with all your mind, and you shall love your neighbor as yourself, sums up the imperative for Christians to promote a whole, a healthy heart, which refers to the body, mind, and spirit, in order to be able to carry out the commandment to love God, to love self, and to love your neighbor. It is the failure of Christians to live as role models for the calling as described in 1 Corinthians 13. Now abides faith, hope, and love, but the greatest of these is love, that has resulted in the perceived need by a majority of citizens in some areas, Oregon being one, for laws to preserve the right to die with dignity. Christians are to follow Christ's example, empowered by the Spirit within. We are to bear one another's burdens and thus fulfill the law of Christ. We are instructed to reach out to the believers as the parable of the Good Samaritan and the parable of the separation of the sheep and the goats. To the extent you did it to one of these my brothers, even the least of them, you did it to me. Christians have a responsibility to reach out to each other and to their neighbors, and to be instruments of Christ's love and caring at this crucial stage of life, dying. Parish nursing as a ministry strategy to address the church's stake in dignity and dying can best be addressed by examining the roles of a parish nurse. The roles are, put them up for you. The roles of the parish nurse are a health assessor, health promoter, health educator, health counselor, trainer of volunteers, and health advocate. These roles and functions are considered the independent practice of nursing by state nurse practice acts, and hence do not require physician orders. Parish nurses work in along with the health committees of the congregation, or a health council, which may include other healthcare professionals, educators, laypersons, to implement a health ministry program, which is much broader than just a parish nurse program in the congregation. Parish nursing and health ministry programs do not reinvent the wheel. They use the community resources more efficiently through collaboration and sharing of resources. So many times people think, well, the parish nurse is going to be a home health agency or something like that, but parish nursing is there to coordinate the community resources to use them more effectively. As health assessor, prior to implementing any health program in a congregation, the parish nurse must assess what the needs of that congregation and what the wants of that congregation are. and especially around the issue of dignity in dying. These issues should be of interest to all age groups, from the adolescent to the older adult, since a life-threatening injury or illness can strike at any time. It concerns each one personally and as a member of a family. Each person comes with a unique perspective based on the spiritual maturity, prior experience with the dying process and death, sense of community, and the perceived immediacy of dying. Many Christians have subtly embraced the prevailing American culture, which values youth and productivity to define worth, and denies death by withdrawing from those who are dying. There is a reluctance to discuss issues around one's own death. These issues are best addressed within the context of the teaching and preaching of the church prior to the crisis occurring. The parish nurse on the ministry staff of a congregation has an opportunity to gather information on the readiness of the congregation to become a place of healing and wholeness and a caring community. Informal assessments may be done by talking with the various groups and individuals in the church, by observing how they participate in learning forums such as Christian education classes. And formal assessments are done through structured surveys, interviews, and gathering of statistical and demographic information about the congregation. A healthy congregation is essential if members are to be effectively reach out and promote health and wholeness in its neighbors. As a health educator, the parish nurse starts from what is known and proceeds to what the people want to know, and hopefully creates a want to know out of the assessed need to know. By raising the level of awareness of issues, the goal of health education is to provide information which is appropriate to the level of understanding and the learning styles of the participants. Older persons learn in different ways based on their prior education and experiences, which are very different from the adolescent who needs a total media production. Educational topics concerning dignity and dying may include dignity and worth of each individual, pain and suffering, the dying process, a caring congregation, advanced directives, funeral planning, estate planning. The one congregation in the DC area has a course called pre-resurrection planning. All topics must be factual, taken from current knowledge while incorporating biblical teaching and faith practices. When possible, authorities in the topic areas are recruited to provide their expertise and experience in the field. Congregations have amazing wealth of expertise. They just have never been used because we have never encouraged this approach to health, and people really don't see themselves as health ministers. The health promotion implies more involvement of the participant. It's not just the giving of information, but the planning of experiences which implement the health education topics through topical Bible study, workshops, to actually planning your funeral, estate, or developing advanced directives, and the organizing of support groups for those experiencing pain and suffering, dying, caregiving, or bereavement. The parish nurse may not lead all the workshops, Bible studies, or groups, but may be involved in the planning to ensure the holistic approach and understanding of health, illness, and dying as an integrated experience. The parish nurse is a health counselor. The parish nurse is a good listener who hears the concerns of the dying and the caregivers. She has knowledge of the physical progress of disease and dying, as well as the impact of caring relations in community, the sense of self-worth and optimism, and the need to find meaning in suffering and purpose for living on the dying process. Through a caring relationship, she provides the strength through prayer and presence, the will through encouragement and empowerment to make decisions, and the knowledge needed to make informed healthcare decisions. She gets inside the skin of each of her patients in order to know what he needs. She is temporarily the consciousness of the unconscious and the love of life for the suicidal. As a trainer of volunteers, the parish nurse cannot physically or emotionally meet all the health needs of the congregation and the community it serves. In order to take the message of health and salvation to all the members and to the neighbors, the parish nurse must train volunteers, lay health ministers who are called to use their time and gifts for specific aspects of health ministry of the church. Volunteers are frequently the connection of a dying person to the caring community. This connection promotes self-worth and a tangible example of Christ's healing, even in the face of physical death. Volunteers can be trained for many activities which support a dying person: the ministry of presence, telephone reassurance, friendly visiting, respite care for the caregivers, household chores, meals, recreation opportunities, transportation to appointments. And some are called to accompany the person in the dying process. And many of you probably have heard of the Stephen Ministries, which trains volunteers to accompany people through all sorts of crises. The role of the parish nurse may be to inspire a commitment to volunteer, to provide the needed skills and knowledge, and most important, to be an ongoing resource and encouragement to volunteers through individual and group meetings. The parish nurse must assure the availability of support if the volunteer runs into a problem beyond the scope of their training. As a health advocate, the parish nurse is in a unique position of using the knowledge of and acceptance by the healthcare system, as well as being accepted by the faith community. This position allows her to be the mouthpiece for those too weak or withdrawn to speak, to be an advocate for the vulnerable people who lack the strength, will, and knowledge to speak for themselves regarding their desires and concerns about their treatment during terminal illness and the dying process. If their physical pain is not adequately being controlled, the parish nurse can seek appropriate medical interventions. The parish nurse may use her skills and knowledge to heal broken relationships and to promote a sense of belonging to a caring family and a caring community. If the environment, such as a nursing home or an intensive care unit, is not promoting dignity and self-worth, then the parish nurse may advocate with others for changes. The parish nurse may organize intercessory prayer change, the ultimate in advocacy. Parish nursing is a ministry strategy to assist individuals to peaceful, natural death as ordained by God. However, the parish nurse is only as effective as the people whose lives she touches as she carries out her 5 roles. The success of parish nurse ministry is the inspiring of others to health ministry by reaching out from their wholeness to their brothers and sisters and their neighbors as caring disciples of Christ, to touch in tangible ways those who are experiencing the physical pain from disease, the emotional pain from lack of self-worth, the pain of alienation and the lack of caring relationships, and the spiritual pain of lack of meaning and purpose in life, and especially to those who are dying without dignity and hope. I do want to give you 2 telephone numbers for further resources. I have brochures for the Health Ministries Association up here on the front table, but the telephone number, if you want further information, is 1-800-852-5613. That's Health Ministries Association, 800-852-5613. And the Parish Nurse Resource Center, which is here in Chicago, at 708-696-8773. That's 708-696-8773.
Not a question, but a comment. I was recently impressed to see a church where, in addition to the pastor's names on the signboard, they listed the parish nurse. I think it's incumbent upon all of us in our congregations to give the parish nurse program that level of support.
Thank you very much for that comment, because it is one of the things that we see parish nursing as a person or a health minister is being on the ministry staff of the congregation. Just like you have a health minister, a director of Christian education, a parish nurse or a health minister is part of the ministry staff and should be incorporated in all the staff meetings and activities in the planning of the congregation.
Hello. My wife is a parish nurse, and as a seminarian, and speaking with a variety of pastors around and being excited about the parish nurse program and what it can give to the community of faith, the question I get most from pastors is what sort of theological training, if this person is to be a part of my ministry team on staff, eventually paid by my church, without any specific nursing roles of taking care of bandages, changing, all the typical things that people think about when they talk about a nurse. What sort of things is she going to bring to my staff from a theological perspective, incorporating that into nursing? Could you speak to that, please?
Yes. That's probably one of the areas that we are really working on. Parish nursing is very much of a grassroots level. Most of your parish nurses are even administering in their own congregation as volunteers as a start, and may move into a paid position in their own church or other churches later on. But there had been no standard of educational preparation, the only requirement being that they be a licensed nurse in the jurisdiction where they're practicing, and that's a legal concern of congregations. However, we did have a group that was convened last year to identify those knowledge and skills that a parish nurse needs beyond basic nursing education. And most of you know that basic nursing education can be a 2-year program, 3-year program, 4-year program, or a master's program. So that there's really little standardization with what basic nursing education is. So what we did is took the baccalaureate level preparation, identified the knowledge and skills at that level, and then those additional knowledge and skills that a parish nurse needs to get either through a continuing education program, and there are several. They usually run 3 weeks or maybe a couple intensive weekends to provide those skills, and most of those skills are more in the theological area. Those formal education programs at the master's level are, many of them are joint degrees, like Azusa Pacific's program, where it is in the School of Theology, and they get a degree from both the School of Nursing and the School of Theology. So there's really not a real standard, but we have guidelines now, and we are addressing the theological preparation that nurses need to have over and above the general knowledge that they have through their own faith practices and study.